Hello, everyone. I'm Dr. Nina Filip. I'm an associate professor at the University of Medicine and Pharmacy, Grigore Popa from Iasi. Dear colleagues, it's a great pleasure to be here today to discuss a topic that has important transformation in modern medicine. Um, we will speak about homocysteine. The title of my presentation is Homocysteine from neglected biomarker to central pathogenic link in medicine. For many years, homocysteine was regarded as laboratory parameter associated with cardiovascular risk. However, accumulating evidence suggests that it may represent a fundamental biological mechanism connecting several apparently unrelated diseases, including cardiovascular disorders, neurodegenerative disease, pregnancy complication, metabolic dysfunction, and osteoporosis. Today I will review the current evidence supporting the role of homocysteine not only as biomarker but also as a potential mediator of disease. Homocysteine. Homocysteine is a amino acid. Amino acid generated during the methionine metabolism. Methionine is one proteinogenic amino acid, but homocysteine is non-proteinogenic amino acid. The story of homocysteine started in 1916 when the American pathologist Kilmer showed that children with homocystinuria develop severe and premature atherosclerosis. This observation was very important. At the time, then cholesterol dominated discussion of cardiovascular disease. Kali proposed that elevated homocysteine itself uh, could provoke direct toxic effect on the vascular wall. His hypothesis was initially met with a reservation and for many years remained on the periphery of medicine. Today, many of these original observations have been validated. Epidemiological study demonstrated that even moderate elevation in plasma homocysteine were associated with increased cardiovascular risk. However, over the last 2 decades, research has expanded considerably. Elevated homocysteine levels have been linked to cognitive decline like Alzheimer's disease, to chronic kidney disease, pregnancy complication, osteoporosis, and different inflammatory conditions. This broad spectrum of association raises an important question. Is homocysteine a simple marker reflecting underlying disease process, or does it activate contribute to disease pathogenesis? Understanding the answer to this question has important implication for both prevention and also personalized medicine. Few words regarding the homocysteine metabolism. Um, to recognize the clinical significance of homocysteine, we must first understand its metabolism. Homocysteine is formed as an intermediate product during the conversion of methionine. Once generated, homocysteine can follow two major metabolic pathways. The first one is remethylation, through which homocysteine is converted back to methionine. This pathway requires folate and vitamin B12 as essential cofactors. The second pathway is transsulfuration, where homocysteine is converted in cystathionine and after that in cysteine. This process depends primarily on vitamin B6 and the enzyme cystathionine beta synthase. Any disruption of these pathways can result in elevated plasma homocysteine concentration. Thus, homocysteine levels represent the interaction between genetics, nutrition, and metabolism. Homocysteine concentrations are generally classified according to severity. Normal levels, they are between 5 to 15 micromoles per liter. The values between 15 and 13 micromoles per liter are considered mild elevation. Levels between 30 and 100 are classified as moderate. And finally, the value higher than 100 micromoles per liter, they're considered severe, and they're usually associated with metabolic disorders. Importantly, recent evidence suggests that even mild elevation may have significant biological and clinical consequences, particularly when present over long periods. Higher value of homocysteine compared with the normal value is named hyperhomocysteinemia. The cause of hyperhomocysteinemia can be divided into genetic and acquired factors. Among genetic factors, the most widely studied are polymorphisms of the meta-tetrahydrofolate reductase gene, particularly C677T variant, which reduce enzyme activity and impairs folate metabolism. Acquired causes are more common in clinical practice. This include deficiency of folate, vitamin B12, and vitamin B6, chronic kidney disease, hypothyroidism, diabetes mellitus, aging, smoking, and several medication. Importantly, many of these factors are potentially reversible ones, highlighting the clinical relevance of identifying elevated homocysteine levels. One of the strongest arguments supporting a pathogenic role for homocysteine comes from experimental study. Elevated homocysteine promotes endothelial dysfunction by reducing nitric acid oxide and impairing vascular relaxation. It increases oxidative stress through excessive generation of reactive oxygen species, resulting in cellular injury and lipid oxidation. Homocysteine also stimulates inflammatory pathways, promoting the production of pro-inflammatory cytokines and contributing to chronic low-grade inflammation. Recently, researchers have demonstrated that homocysteine influences epigenetic regulation by altering DNA methylation patterns and gene expression. Together, this mechanism provides a biological plausible explanation for the association between elevated homocysteine and chronic disease. The strongest clinical evidence linking homocysteine to a disease comes from cardiovascular medicine. Many observational studies have demonstrated association between elevated homocysteine and coronary artery disease, ischemic stroke, peripheral arterial disease, and venous thromboembolism. The mechanisms include endothelial injury, accelerated atherosclerosis, oxidative stress, and thrombogenesis. Meta-analyses have suggested that every increase of around 5 micromoles per liter in plasma homocysteine is associated with increase in cardiovascular risk. Although intervention trials have produced mixed results regarding cardiovascular event reduction through vitamin supplementation, homocysteine remains an important marker of vascular health and risk stratification. The relationship between homocysteine and neurological disease has become increasing in last years. Elevated homocysteine levels have been associated with Alzheimer's disease, vascular dementia, Parkinson's disease, cognitive decline, and depression. Several mechanisms may explain this observation. Homocysteine can induce neuronal injury through excitotoxicity mediated by an NMDA receptor activation. It can also increase oxidative stress within neural tissue and impair several microvascular circulation. Elevated homocysteine may accelerate neurodegenerative processes through inflammatory and epigenetic pathways. Pregnancy represents another important area where homocysteine appears to play a significant role. Elevated maternal homocysteine levels have been associated with recurrent pregnancy loss, preeclampsia, placental insufficiency, and neural tube defects. The proposed mechanism involve impaired placental vascularization, endothelial dysfunction, oxidative stress, and of course, thrombotic complication. The success of folic acid supplementation um, programs provide indirect evidence of the importance of one carbon metabolism and homocysteine regulation during pregnancy. This remains one of the clearest examples of how understanding homocysteine metabolism can directly improve public health outcomes. Less recognized but increasingly important area of research involve bone health. Studies have shown association between elevated homocysteine level, reduced bone quality, osteoporosis, and increased fracture risk. Unlike a traditional measure of bone mineral density, homocysteine may affect the structural integrity of bone. Experimental evidence suggests that homocysteine interfere with collagen cross-linking, weakening connective tissue architecture and compromising bone strength. A practical question for clinicians is whether homocysteine should be measured routinely. The short answer is not in the general population, but yes in selected clinical settings. However, homocysteine assessment may be valuable maybe important, including in some situation, including premature cardiovascular disease, unexplained stroke, cognitive decline, recurrent pregnancy loss, suspected vitamin deficiency, and strong family histories of vascular disease. When elevated levels are detected, clinicians should investigate potentially reversible causes, particularly nutrition deficiency and underlying metabolic disorders. Thus, homocysteine measurement may provide clinical information in careful selected patients. Management strategy primarily focus on lowering homocysteine concentration and correcting underlying causes. Lifestyle modification includes smoking, cessation, regular physical activity, and to try a healthy diet rich in folate containing foods. Supplementation with folic acid, vitamin B12, and vitamin B6 can reduce homocysteine levels in many patients. Looking ahead, future intervention may involve precision nutrition, genotype-guided supplementation, and therapy targeting specific metabolic pathways. The challenge will be determining which patients derive the greatest clinical benefits from intervention. Several important questions remain unanswered. We still need to clarify the extent to which homocysteine directly cause disease, rather than simply reflecting underlying pathology. Future research should focus on identifying vulnerable population, understanding gene-environment interaction, and integrating homocysteine into broader system biology frameworks. Advances in genomics, metabolomics, and AI may help uncover previously unrecognized relationships and therapeutic opportunity. The future may provide that homocysteine can be not only a biomarker, but also can be modified therapeutic target. In conclusion, homocysteine has evolved from relatively neglected biochemical marker to a molecule of considerable scientific and clinical interest. Accumulating evidence suggests that elevated homocysteine contribute to disease through endothelial dysfunction, oxidative stress, inflammation, thrombosis, and epigenetic dysregulation. Its influence extends across multiple organ systems, including the cardiovascular, neurological, reproductive, skeletal, and metabolic domains. While many questions remain, homocysteine appear to represent a common biological thread linking diverse chronic diseases. Therefore, it may no longer be appropriate to view homocysteine merely as a marker of disease. Instead, it should be considered as a potential participant in pathogenic mechanisms that drive human pathology. Thank you very much for your attention.